presentation tonight. Dr. Chau is going to be speaking on blood pressure and heart failure because the two go hand in hand, and you will learn that from tonight. He is a physician out of Advocate Christ Medical Center. He is board certified in cardiology. He went to medical school at Virginia Commonwealth University Medical Center, residency at Medical University of South Carolina for internal medicine. His fellowship was in advanced heart failure and transplant cardiology at Mount Sinai Hospital, advanced heart failure and transplant cardiology. And his fellowship was in cardiovascular disease at Virginia Commonwealth University Medical Center. And that was in cardiovascular disease. So he's very well-rounded. And he is the father of a new baby, 5 months old. So his life is very busy right now, and I don't know how much sleep he's getting. So, but he's functioning well.
Yeah. Thanks, everyone, for coming here. Thank you, Susan, for giving me this opportunity. So before coming to Christ, I was at in the East Coast for about 3 years or so. And yeah, as Susan said, I've been a dad for about a couple of months now. And the biggest lesson I learned is really commitment and being patient and with my son. So all that really qualities I feel translate to what preventing heart failure is all about, and that's what we're going to talk about tonight. And how is that going to make the heart functional and not dwell on the failure aspect of things?
Let's see.
Otherwise, I can stand behind there.
Try one more time.
There you go. So I really don't have any disclosure except for stating the heart being heart healthy. Before we begin, I just want to take a moment to show you this colorful slides of kind of what we offer at Advocate Christ, our gamut of taking care of patients with heart failure and with patients who have advanced heart failure, and all the technology we can offer at Christ down the street. These are the advanced practice providers and the nurses and the medical assistants that help us along. If you recognize any of these faces at the local farmers market or Walmart, feel free to say hi to them. And then this is us, all the doctors, and we have plenty of them, and hopefully we'll just see you in a flea market rather than in our office, really. So the focus of today is mainly 3 points, and these 3 points are what really I want to drive home. And if you can take these 3 points away, I'll be really happy. So really, the main thing is heart failure and hypertension is bad. And in targeting blood pressure to treat hypertension is less than 130/80. That's kind of the goal. And then if you have a lot of, if a patient has a lot of multiple risk factors for heart failure, then there's some role of lab testing. And that's really research that are going to be done, in the future. So what does the heart do? At the basic core, the heart is essentially a pump that pumps blood to the rest of the body. And then the blood would flow back into the heart, and the heart pumps again to the rest of the body, and the cycle kind of ensues. And when I talk to my patients, I like to use the analogy of a house. A heart is kind of like a house. And in the house, you have, probably have to do this. So in a house, you have the plumbing system. The plumbing system carries all the water throughout the house and provide you with, good toiletries and everything like that. And you have the electrical system providing the power that powers your light bulbs and all the computers. And then obviously the most important part of the house is the walls and the structures, the windows, the doors, and all of that such. And when we talk about the electrical system in the heart is where the electrical signals within the heart going throughout the muscle itself. And when that goes bad, we call that arrhythmias. And when you have an arrhythmic condition, then you go see an electrical physiologist. And when the supply of the blood, the oxygen, the nutrients going to the heart muscle itself is injured or damaged, and we call that coronary artery disease on the right hand over there. And the interventional cardiologists are the ones who specialize in those areas in terms of stentings and blockages to the heart muscles. So all of that is really under the direction of a general cardiologist, kind of your regular heart doctors, and that's really key in terms of heart health. So what I do is I specialize in the heart muscle itself. What's wrong with the heart muscle? So on the left side here is a picture of a normal heart. What does it look like? With two chambers up here on the top and the two chambers in the bottom that kind of pumps the blood to the rest of the body. So when a some sort of stressors, whether it's just something you're born with, a genetic mutations, or something that's environmental risk factor that causes the heart to be stressed, to be injured, to be damaged, the heart changes over time. So some of that changes could be on panel A there when the heart gets really thickened, or when the B doesn't show up, but either way. So when the heart can get thickened or it gets really flabby, and like this right here gets dilated big, and that can lead to heart failure. So heart failure itself is a syndrome, which means it's constellations of different things, and when you put it together, it causes heart failure. So as I said before, there's something abnormal within the heart muscle itself, and we can detect that abnormality based on imaging, the pictures, EKGs, lab testings, and all of that together. When the heart cannot supply enough demand to the body itself, and the body gets really, really stressed, all of that kind of coalesce together and cause patients to have symptoms. So symptoms are like shortness of breath, leg swelling, fatigue, feeling tired when you're doing exercises or moving around. So all of that together is something coalesce together, forming what is called heart failure. And heart failure itself comes in different varieties too. One of the main varieties is when the heart squeezing functions, when the heart cannot pump blood enough to the rest of the body, as you can see here. And this is a picture of one of my patients, an echocardiogram or heart ultrasound. The heart itself is kind of jiggling. It's not moving as well as it should be doing. And we call that heart failure with reduced ejection fraction, or systolic heart failure. Again, this is weak heart, or the squeezing function is weak. As opposed to that, as you can see here, the squeezing function of the heart is moving very well, but the heart is very thick, it's very stiff. So when the heart is stiff, it cannot be filled with blood inside the ventricle, the chambers. So blood backs up into the lungs, into the legs, causing all the symptoms that you're having. So that is something called diastolic heart failure, or heart failure with preserved EF. And about half of the patient population would have one form or the other, the diastolic or the systolic heart failure. So let's stop a moment here and kind of take a poll. Which conditions would you not want to have? So A is common cold, B is breast cancer, C is heart failure, D is heart attack, and E is coronary artery disease. C?
Oh,
All of them? Yeah, that's true. You don't want any of that, even the common cold. So since we're talking about heart failure, this is the correct answer. And let me tell you why, okay? So when we talk about coronary artery disease, the blockages and that's going on in the heart, we talk about ASCVD here. This is the risk of you having a heart attack, strokes per year, right? Or dying from that too. And it's not as bad as when someone who's living with heart failure. If someone is living with heart failure and that patient goes to the doctor and the doctor pat him or her on the back and say, you're doing really good. See you in a couple of months. That patients have a pretty high chance of dying every year. And that chance gets worse if the patient is coming in and out of the hospital for heart failure exacerbations, upward to 40, 100% of the time. So when you compare that to cancer, for example, okay, and I'll use the example of breast cancer. So breast cancer, even in the most worst form of breast cancer, distant metastasis, metastatic breast cancer, the chance of dying per year is not comparable to someone who's living with worsening heart failure. So now that you can see why heart failure is really not a good condition to have, and why looking at it and preventing it and detecting early on is really helpful in treating that disease. So I believe that an ounce of prevention is worth a pound of cure. For bonus points, do you know what the context of that quote from Benjamin Franklin? Not really. So if you read the fine print here, it's really, he's talking about fire. And that's a life lesson for me too, is always read the fine print in a contract. So this context is what Mr. Franklin was talking about was in the 1700s, well before the American Revolution War, and he was living in Philadelphia, and they asked him to create a system where we can prevent fire from happening. And they want him to talk about creating a fire fighting system, with fire hydrants and engines and all that, jazz. But what he focused in this essay was about how each individual can help within their own home in terms of fire hazards, like reducing ambers, making sure that everything is, put out at the end of the day in terms of stoves and all that. So essentially the forerunners of like Smokey the Bear, So in that instance, I really want to emphasize how much of that is really striving or trying to prevent the progression of heart disease. And heart failure itself is a progressive disease. It progresses over time, and ultimately it's hard to treat, manage at the advanced stage of heart failure. So when someone say that the patient comes in to the office for symptomatic heart failure or stage C, D over here of heart failure, they have these three constellations that I spoke earlier: the abnormal structures with the damages to the heart, signs that we can detect on lab imagings, and other testings, and then that patient feel bad about having heart failure. Well, you don't develop stage C or D overnight. Well before that, a patient would have stage A and D. And they would have the risk factors in terms of having heart failure. So that's stage A. If that patient doesn't get the risk factor addressed enough, then that would progress to having damages to the heart itself, which is stage B. And then ultimately, when you have symptoms of heart failure, then that will be stage C or D. And along the way, when a patient gets to the symptomatic aspect or the far right of your what you're seeing, the medical therapy or the medicines that patient will be on is really to slow down the disease progression. It doesn't stop the disease itself. It doesn't reverse the disease, and it doesn't cure it. So that's why it's very important for us to detect heart failure very early on in stage A or B, because we have plenty of tools to prevent the disease from actually happening, and to prevent if the patient gets to stage B, the middle column here, we can actually prevent the structures from it getting worse again. So let's talk about the risk factor for heart failure. Which one of these are risk factors for heart failure? So A is hypertension, B is diabetes, C is hypercholesterol or high cholesterol in general, or D, bad habits, which no one ever has. All of it. Yeah, that's very true. So all these factors can lead to condition that predispose you to heart failure, or by itself can cause heart failure itself. So today we're going to talk about mainly hypertensions, as the title suggests, because hypertension or high blood pressure is the most common risk factor that everyone shares in terms of having a predisposition for heart failure. So, so the other analogy that I like to use when I talk to patients is a heart is kind of like a water pump. It pumps water, so the water pumps blood, water out of itself, and it travels through the pipes. And as the water travels through the pipes, it generates some sort of pressures. So similarly, when the heart pumps the blood and the blood goes into the blood vessels and that travels through the rest of your body, that pumping itself and everywhere that the blood travels to, you'll get some sort of pressures. And the pressures when the heart is pumping is called systolic blood pressure, or the top number right here. And then when the heart is not pumping, when it's relaxed, getting blood filled into the pumping chambers, there's certain pressures within that system itself, and that's called diastolic blood pressure, or the bottom number. In the medical field, we really worry about the top number more than the bottom numbers. I know a lot of patients ask me these questions because we have a lot of evidence just showing that the top numbers really matters as opposed to the bottom numbers. So when the heart is pumping blood out to the aorta, this is the main blood vessel, the main pipes that supply the rest of your body. When you have high blood pressure, there's a lot of resistance against that pumping, right? So when we define hypertension, we usually use the number 140/90. So your blood pressure is above 140/90. That means that more than likely that patient has hypertension or high blood pressures. So over time, when that resistance against the blood flow gets so much, you know, the heart start having a lot of damage. It's saying, I'm pumping too hard and I cannot handle the stress, and the heart changes over time, and that causes damage, injury to the heart, and over time that can cause the heart to fail, and the heart cannot pump as efficient as before. So we all kind of understand that high blood pressure needs to be treated, but what is the target for high blood pressure, right? What should we treat the blood pressure to? So a lot of studies have been done already, and to summarize it, when a patient have high blood pressure, we tend to try to get the blood pressure to 120 to 130, if not lower, because when we get to that range and we compare that to patients who doesn't get to that range, 120 to 130, the top number, those patients with that target has about 30% lower rate of heart attack, heart failure, or other cardiovascular events. And then the mortality or the chance of dying is get reduced around 25% too. So when we take patients with high blood pressure and we stratify them on the risk of them having heart failure in the future, 5-10 years from now, and we look at the high-risk patients or patients at high risk of developing heart failure and targeting that goal less than 130/80, there's actually a 54% risk reductions of developing heart failure. So that's why we want to target the blood pressure of 130/80 or less. And that would reduce the chance of heart attacks, strokes, or heart failure. And again, high blood pressure is not very good for the heart health. So, sure.
Talk about medications. What
Yeah.
about lifestyle changes? They all talk about, exercise, eating better. I mean, how do those account for any reduction in risk?
Yeah, so lifestyle changes is definitely foremost and important in treating all the conditions, the chronic conditions. Usually, as you, when a patient is young, in the 40s, 50s, lifestyle changes. So eating better, less salt in the diet, usually gets around 5 to 10 points lower in terms of blood pressure control. So remember that when the as you age, as a patient age, 60, 70, 80. So my dad is 75, okay? So his pipes, his blood vessel pipes get stiff over time. And that's kind of the nature of aging. So 5, 10 years ago, he was telling me his blood pressure was 100 over like 70, so 60. He was really happy, right? And then for the last year or so, his blood pressure became 130s and 140s, just because his pipes, his aorta, his blood pressure got stiff over time, and that's kind of nature of aging. Some people age faster than others in terms of that blood vessel, and the blood pressure, and then as a result of that, the blood pressure goes up just because of that. So I told my dad, you gotta take medicines, otherwise the blood pressure gets too high, and I don't think any lifestyle changes would help him. He's around 120 pounds, eat like minimal a day and kind of work out every day kind of deal. So lifestyle changes is really good and important. But as you age and older, the body change with time, and we need to take some medicine to help with the blood pressure. That's a good question.
Does the exercise make a huge change?
Yeah, exercise kind of goes along with lifestyle changes. Yep. So exercise itself kind of helps all the blood vessel dilate, relax, and allow that blood vessel to get less stiff, and helps with lowering blood pressure.
And what about stress?
That too, yeah. My friend is taking like 3 different medicines. He's like 3 years older than me for heart, for blood pressure. And he tells me every day I want to scream. I'm gonna have strokes every day doing work, But definitely having less stress, thinking happy thoughts are really good for for
It
that.
does
Yeah.
make a big difference.
Yep. Yeah.
What type of exercise do you recommend?
What type of exercises? So mainly both aerobic and anaerobics. So aerobic is when you're on a treadmill, when you're walking, okay? Ideally, you should try to get your heart rate above 100. Usually I tell my patients, trying to keep that heart rate up. It's really conditioning the heart and conditioning the body to adapt to that. And then weight training. Weight training helps with the body getting stronger and adapting, and its ability to adapt to stressors. Yeah. Exercise, mainly, and what type of exercise should be combined together. 20 to 30 minutes, kind of like 3 times a week at least. Yeah, good question. Yeah.
Sleep also does it.
Yeah, sleep is definitely an important part. Sleep, I don't get enough sleep, but recently my wife has taken over the 4 a.m. so that way I can sleep through the night. And sleep lets the body relax and recharge itself. If you don't recharge the battery will run out. So the body is similar. When you don't recharge the body becomes stressed. And when the body is stressed, high blood pressure, heart rate, and all that stuff.
What's the ideal level, supposing you age?
I'm sorry?
Supposing you age about 80, what could be ideal BP level?
Blood pressure, same thing. So when we talk about high blood pressure, one thing I didn't mention was actually this study itself. It's called a SPRINT trial. So this study actually looked at patients who are above 65, and then they actually try to factor in and enroll enough patients who are above 80 into this trial. And what they found was consistent with what I told you earlier. targeting the blood pressure, usually less than 130/80 is good for them long term. So obviously, when I say, you should take pills, when you really want to target blood pressure less than 130. On average, that patient would take about 3 pills in addition to lifestyle and exercise and all that interventions. So it's a little bit more time consuming, more commitment. But if that patient gets symptomatic, they get dizzy, they kind of feel woozy when they are on that much medicine, then obviously that benefit, the risk of them falling, on the floor, passing out, would outweigh the risk of heart attack, strokes, long term. So I tend to be more liberal in the patients with advanced age, unless I can, if they can tolerate, they can take the medicines without any symptoms.
What would you say about salt level and all this?
Yeah. So salt level, I tend to tell my patient 2 grams. So 2 grams of salt. So that means that no additive salt in their diet, and no table salt. Okay. What I mean by that is that there's no way you cannot eat salt in your food. That's just impossible, right? Tomatoes, pasta itself has salt. So any of that food is good. You shouldn't add any more processed food. You shouldn't have table salt in your food. Growing up, curry is definitely, one of my favorite things when I was in med school and then in residency. And it's kind of the nature of the food, the seasoning itself. We should enjoy life, right? And enjoying life is part of, being tasty. And having enough of the food and not adding more seasoning to that is definitely helpful. Yeah.
How come the stress increases blood pressure, like it shoots up? Anytime when I have like fight or anything with the argument,
Yeah.
next night I know my blood pressure just goes up.
Yeah. To the lady in the back, kind of the young lady in the back saying, stress. What stress does to the body itself. So when you're stressed out, whether it's physical stress, like someone is about to jump on me, or 2, emotional stress when I'm having a fight with my wife, right? All of that kind of activate the same signaling pathway in the body, the fight or flight, pathway. So back when we were, 100,000 years ago, that fight or flight system is very, very, very robust. When you see a lion coming at you, you'll kind of jump up, your blood pressure goes up, your heart rate goes up, and it's trying to fight, the lion. And as we kind of evolve into this modern age, we don't have that line anymore, but the stress physically or emotionally is kind of that lion, right? And anytime that you have all that stress, you activate the sympathetic drive, and the blood pressure, your adrenaline goes up, and adrenaline causes your blood pressure to go up. Yeah. So that's okay if the fight is once in a while, right? But if that stress become every single day, the adrenaline gets amped up every single day, and that has a toll on the body. Yeah.
You're not allowed to sleep.
Yeah, and then you start thinking about how to how to calm yourself, what's going on. And for me, I'll be like, what can I do for my wife the next day, right? So all of that keeps me up at night, and I can't sleep. Yeah, and that causes further stress. You're right in that. Yeah.
So once you start on an antihypertensive drug,
Yeah.
you're going to become dependent on it. There isn't any turning around because of the aging and the arteries, the hardening of the arteries.
Yes and no. So once you're on the medicine is maintaining the blood pressure at an acceptable level. And some patients, in terms of, exercising, dieting, that can reverse the blood pressure, and then we can get you off of that blood pressure medicines. However, the caveat is that you still have high blood pressure for the rest of your life. So hypertension or heart failure is a chronic condition, is a condition that one has for life. So the blood pressure gets up again above that 130 to 80 magic, number, then that person should be back on medicine again.
Wouldn't they just like lower the medicine
Mhm.
maybe?
Yeah, exactly. Yeah.
Now, there's a different medicine work different way, right?
Mhm.
The, blood pressure.
Yeah, so different medicine works different way. And there's multiple medicines that attack the high blood pressure pathway different ways. And it doesn't really, in terms of treating blood pressures, there's no medicine, one particular medicine that works better than the other. It's more or less in terms of the side effect of it. Okay, to give you one example, amlodipine or Norvasc. So Norvasc is a powerful blood pressure medicine, and it really lower your blood pressures. The side effect of that is sometimes leg swelling. If a patient has leg swelling because of Norvasc, then the doctor can change that medicine to something else, like lisinopril or hydrochlorothiazide, for example. But there's no one specific medicine that works better than the other. Yeah. The key is just trying to get the blood pressure below 130.
So when they add a secondary drug,
Yeah.
like Norvasc, and they append losartan,
Mhm.
what's happening? Is that two different approaches
Yep.
to the body?
Mhm.
Okay.
Yeah. So when blood pressure, when we cannot control the blood pressure for one pathway, maybe the other pathway can get a little bit, amped up. So we want to control that. It's kind of like whack-a-mole, except for we hope to whack all the moles. Yeah.
So how does it affect the kidney? What happens to the kidney when you take all these blood pressure medication?
Yeah. So that's a good point. So long-term wise, and we don't have time to talk about the kidney in this, but high blood pressure itself over time damage the kidney too. And that high pressure, we want to take off, right? But we don't want to lower the blood pressure so much that it affects the kidney, because the kidneys need the blood flow, needs the pressure, right? So that's a balance in terms of having the right amount of dosage and right amount of medicines to help with kidney health. So the other thing that we have to think about is that usually when a patient has high blood pressure, they usually have other things going on too, diabetes, obesity and all that stuff. So when all of that can interact with each other, that can cause the kidneys to not do well. And treating the medicines that treat high blood pressure actually protects the kidneys from all those damages too. Yeah, lisinopril, and there's a new drug in town called Farxiga or Jardiance. The regular name for that is empagliflozin or dapagliflozin. So those two classes of medicines, and losartan is the other class. Those medicines actually protects the kidney long term.
Protect the kidney.
And
It
that's-
slows down the progression of kidney
So
failure.
that's really why it's important to have your lab tests all the time.
Mhm. Yeah, exactly. Yeah. So the medicines has side effects, and we monitor those side effects with lab tests. Yeah. Usually every 3 to 6 months. Yeah. Definitely at least once a year. Yeah.
Does a general, regular exam, blood works like, that you would get typically, what is it, CBC or whatever?
Yeah.
Would
So
those, anything on there indicate if you're having any kind of heart problem? Would there be anything?
we'll
on
get to
there?
that. That's a good segue. Yes, we'll get to that. Yes. Yeah. Any other questions? Good question. Yeah.
How long do you have to continue taking medications for high blood pressure?
Like-
Because some period of time you will be off the medication.
Yeah, so, so that's when someone living with heart failure and the heart itself get weaker and weaker, or there's other things going on that causes the blood pressure to go down. Okay, so that kind of counteracts with the stiff artery that I was talking about earlier, causing the blood pressure to go up. So in that settings, what we call is that you can handle the regimen that you're on right now. So that's why we take off medicines.
So how often you advise to check the blood pressure? Like,
Once a day, first thing in the morning. Usually that's what I tell my patients. Because taking the blood pressure when you're stressed will automatically cause the blood pressure to be high, and that may not be accurate because it doesn't reflect kind of like the overall conditions of the heart health.
and how often doctor's visit should be, like for the hypertension patient?
Yeah, usually that was with your primary care doctors, every 3 to 4 months, yeah. Yeah.
If you take your blood pressure first thing in the morning, should that be like right after you wake up before you take any medicine? Or should you take your medicine first and then, take your blood pressure in an hour?
Yeah, so with blood pressure medicine, it usually has a 24-hour effect. So it doesn't really matter when you take it in relationship to the medicines, okay? So if you I usually advise my patients to take them on a regular basis and a regular time every single day. So what I mean by that is that, you pick a time that's most convenient to you, and you take the blood pressure either before or after the medicine. And so we talked about high blood pressures and reducing the risk of heart failure by targeting that blood pressure. So to your point, if we miss the boat and there's certain damages or injury that's already been done to the heart because of all these risk factors, can we still intervene? Stage A is when someone has risk factor or heart failure. They can progress to stage B, which means that they have signs of heart failure, abnormal structure that we can detect on lab imaging and imaging. So research is still being done, and a lot of patients, what I would say would be that there's certain tests that triggers certain more tests to detect the damages or the injury that's been done to the heart based on the risk factor that one has. So when a patient has shortness of breath, a lot of risk factors for heart failure, such as hypertension, diabetes, blockages in the legs and the heart, there is some evidence that those patients should be screened for heart failure for the stage B or the pre-heart failure aspect of it with a pro-BNP, it's a lab test, and then an echocardiogram, which is a heart ultrasound. The pro-BNP, to your point, Miss, is that it's a lab test specifically that's in the heart, and I kind of tell my patients that this is a test that measure the stress level of the heart. How stressed is it, and how much stress it is in response to the body, how much stress it is responding to high blood pressure, to diabetes, and how damaged is it from all that going on.
So what is the name of that test you said?
It's right here, pro-BNP. Yeah.
OBN.
Yeah. So that's something that to consider. And a lot of research is still being done to make sure that we're appropriately screening patients and what type of patients should be screened. So more to come in that aspect.
So that's a blood test?
That's a blood test, yeah. Yeah.
And what's a normal for that?
Normal pro-BNP is less than 500, and it's actually age related. So that's got to be adjusted for age. Yeah.
That's something.
And again, this is still, research still being done in terms of how to stratify patients and how to appropriately apply this to the population level rather than individual. So more to come really in the next, a couple of years.
And echo is it usually done after how many years?
So usually a heart ultrasound gets triggered if you have an abnormal lab test. Yeah. Yeah.
And echo is not ultrasound? No, echo
Yeah,
is-
heart ultrasound. Yeah.
Oh, okay.
Mhm. Yeah.
Something that I've learned recently. I thought your blood pressure is pretty much fixed.
Mhm.
I found that is not the case. If I walk up a set of stairs, my blood pressure will change significantly. If I sit down for 5 minutes, it changes back significantly. If I take a
Right.
walk, it changes. How do I know what my actual blood pressure is? It varies so much.
Yeah. How many of you guys kind of similar boat? Everyone? Yeah. Yeah. It's a very common thing to have, really. So blood pressure changes with exercise, changes with stress, changes with kind of daily activities, right? So when we, this is back in kind of when I was in training, I would hand out blood pressures to my co-residents, my colleagues, and we measure blood pressure throughout the day. It changes a lot too, in under normal conditions. And so what we say normal blood pressure should be is kind of artificial, okay? But what we like to do is take an average of blood pressures over the course of a day, all right? So if my patients is really concise and they're really on top of things, they take 5, 10 blood pressure throughout the day. So what I tell them is that you average the top number together, and the average is what I would like to use. Okay, but at the same time, what blood pressure to me is what the blood pressure should be at the beginning of the day when I see you, when I see my patient in the office, and what that trends are, and how can I integrate your data to what I see in the clinic and kind of mesh it together and see if we need more medicines or lifestyle changes to lower the blood pressure. Yeah. So short answer is that your blood pressure definitely changes over time. What truly accurate is kind of like an average of those blood pressure throughout the day. All right. Again, so stage B, we were talking about that being pre-heart failure, which means that, and do I have enough time? Yeah. So when someone has an abnormal structure to the heart, and we can see that on labs and imagings, and that patients are more than likely to progress to symptomatic heart failure, or the stage C and D on the right hand there. So a lot of time we actually have medicines to actually target the abnormal structures of the heart and to reverse it and prevent that patient from progressing forward. So that's why it's important to really detect early on, so that way we can treat that condition appropriately. So overall takeaways, heart failure and hypertension are bad. Blood pressure, we should target less than 130, and then potentially there's a role of additional testings, and that should be discussed with your providers and on a one-on-one basis. So I like to, and this is my son. He's about 5 months now. So my main job at home have to work, and that's what my wife tells me is to change diaper, make sure he's clean. And a lot of time I get really lazy and I don't get committed to what I'm doing. And this is how sometimes I change my son's diaper. And then this is what happened, a big mess, right? So, I leave kind of the story with you being that, commitment to a routine and be patient with the conditions. And really that together forms what we can do to get heart healthy and to prevent having a bad heart health. So if you have any other questions, feel free to. Yeah.
Chemo and radiation, does that always cause heart damage or is there a way to tell if there's permanent damage from that?
Yeah, so chemo and radiation is another entity itself. So a lot of research is going into that. So chemo radiation does not equal heart failure, okay? Similar to hypertension or high blood pressure. A lot of patients have high blood pressure and they never get treated, but they never get heart failure. There's something about the way the body can handle the stress and handle the changes to the heart and the body itself that they never develop heart failure. So same thing, chemo radiations can cause heart damage, and it's hard to tease out how much chemotherapy and how much radiation will lead to heart failure, okay? So that's that's your first part of your questions. The second part of it is that, can we detect heart damages or injury to the heart when someone is on chemotherapy or radiation? So yes, so the guidelines now, in terms of the recommendation from all the studies, is that they do routine heart ultrasound. And that can actually, and then also the test that I was talking about earlier, to detect stresses that are ongoing in the heart, and then whether we should treat them appropriately or not. That's based on the decisions of your healthcare providers and your cardiologists. We do have a cardio-oncology program at Advocate Price. Dr. Pawa is one of the heart doctor. He directs our program in that, and he's a really good in terms of expert.
And another question is, when you say over 50, whatever, you go in for a regular exam, with the primary care, do they have ways of like indication that you're probably having all this trouble, or they just look at your blood pressure and listen to your heart and they go from there, right?
Yeah, so that's a very good question. So stage A, going from stage A to B to C, what we talked about earlier, stage B is really silent. What I mean by that is no one really have a good tool to say out of 100 patients who would have stage B and who would progress from stage B or having those damages and progressing to symptomatic heart failure. It's really hard. So that's why there's still research ongoing and trying to find the appropriate populations to screen. So if someone has shortness of breath for some sort of reason, tiredness, having multiple risk factors for heart failure. So those are the hypertension, diabetes, blockages in the heart, coronary artery disease. So those patients, there may be a discussion about doing the pro-BNP, the lab test, and if that lab test is abnormal, then that would trigger heart ultrasound.
Is
Yeah.
TIA a risk factor too?
Yeah, sometimes, yeah.
So when does the primary decide that I'm ready for the cardiologist to see it?
Yeah, so that's
They sometimes keep you also for so long till.
yeah. So we as a medical community has to do a better job in terms of knowing who to screen for heart disease, and it's really hard. I don't have a magic answer for that, unfortunately. When again, detecting a silent disease is hard to do, and how to implement it throughout everyone and trying to make it as cost effective as possible is kind of a hard thing to do. And I recognize that. In terms of what a primary care doctor can do is, again, listening to you, and you be your advocate too. If you have a lot of heart risk factor, high blood pressure, you listen to your body in terms of having this chest discomfort, having shortness of breath, having a little bit just out of the ordinary. So one thing that I give you an example is, so my dad, so that we don't get one get offended. So my dad started having a lot of shortness of breath because he would be out in the yard and he does like 20 minutes or 30 minutes of gardening. He just get out of breath. And then his doctor, his primary care doctor, start treating his blood pressure. Now he can actually do more, like an hour or two of gardening. So those are the things that are kind of listening to your body and knowing what is not normal to you and then telling your doctors that and be on alert. Yeah.
Is there any like shaking the hands and all symptoms in anywhere in hypertension and heart problem?
I'm not sure if tremors or shaking,
Tremors,
yeah,
yeah.
tremors or shaking, handshaking is part of that constellation. Yeah.
But that's something you should tell your doctor.
Yeah, that's something definitely. Yeah.
I mean, you know. this is-
Yeah.
So what if a person is stage, what is it, C?
Mhm.
Would they be considered for a heart transplant, or is there anything that can be done for them?
Yeah, of course. We have actually a lot of medical advances to treating a patient on stage C or symptomatic heart failure. We have developed really a wide field now. It's really open from medicines to devices to really improve that quality of life. And the goal, as for me as a doctor who specializes in heart failure and a weak heart, is really not to get you to transplant. Really, is trying to make your heart functional again and trying to keep you healthy as much as possible for that long period of time. Yeah, it's not the end of the world. Yeah. Yeah.
I have a question. My mom was on blood pressure medicine probably about 15 years, a very low dose.
Mhm.
Then she had a heart attack, and then she was diagnosed with heart failure. Could the heart attack have caused the heart failure, or could she have had it before and then it was just never diagnosed?
It could be both. I'm not, yeah. So heart attack itself is related to the blockages, the coronary artery disease, and that is a risk factor for heart failure. Yeah. Yes. Sure.
Okay, I was visiting my cardiologist a month ago. And the guy shocked me to death. I almost died at his office. He said, everybody over 75 years of age should be on a blood thinner. And he talked about Coumadin,
Yeah.
and he talked about Eliquis, and I quizzed him. I grabbed him and I shook his head and I said, are you telling me that every single person that you see over 75 years should have a blood thinner? He said, yes, absolutely. No matter what your conditions, you should have it. I have never in my life heard anything as wild as that.
Yeah. So blood thinners itself is to treat conditions that predispose you to having strokes or having blood clots in the lungs and whatnot. So if you have, or someone has a condition like that, definitely should be treated.
I don't know.
So let me get, yeah. So yeah, as you age, that condition become more prevalent. Just kind of like a patient as that patient age, cancer is more prevalent, right? So as you age, those conditions that predispose you to strokes and clotting get more prevalent, and that may be what he is referring to. However, one should have that condition to warrant the treatment for that condition. Yeah.
So aspirin doesn't help enough to keep going after 75? I mean.
Yeah, aspirin is a big topic for another day. But the short answer is that aspirin itself prevents heart attacks, strokes, blockages in your legs, all that such. But then you have to weigh the risk of being on aspirin too. As you age, the chance of a patient bleeding from aspirin is still high. My dad has a big ulcer and he had to get in the ICU for a couple of days. So I told him, his chance of having a heart attack, stroke, is less likely than him, being injured from aspirin. So I told him not to take aspirin. The mainstay of evidence or someone should be on aspirin, again, should be that they have less bleeding risk, and then whether they had already have those conditions, whether they had already have, heart attack, strokes, or blockages. Yeah.
That's not regular aspirin though, isn't it? The low dose aspirin?
Yeah, low dose aspirin.
That's a
baby
big
one.
difference.
Yeah, baby aspirin. Yeah, yeah,
Maybe.
yeah, yeah. Yeah.
What about coffee?
I'm sorry. What?
What about coffee? and
Same
high-
as-
high blood pressure?
Coffee in general are good. That's why I'm gonna. So everything is good and up to moderations. So what I tell my patients, 1 to 2 cups of coffee a day. Yeah. Stimulant wise, again, more stimulants ramps up that stress system. More stress in your body causes the heart to be damaged over long term.
Or I keep on hearing about those miracle drugs, green tea.
Yeah, I do.
How's that affect it?
Yeah, I do 2 cups of coffee in the morning, and maybe a green tea. If I only do 1 cup in the morning, coffee. But joking aside, green tea is similar to, it has a lot of antioxidants and stuff, but it has not yet proven to reduce blood pressures and cholesterol and all that stuff. So it's helpful, but again, moderation. Yeah.
Supplements, like magnesium, fish oil.
Yeah, the only one that may help with heart health is called CoQ10. And that's the only one that I generally tell my patients, but again, CoQ10 doesn't really have a lot of evidence too. And everything else is good, in the right settings, if you low in, calcium or vitamin D, yeah. I think that's the time we have.
Yeah.
Thank you for your idea.
Lots of good questions.
Yeah, thanks for the question.